thank you everyone for having me here to be a part of the clinic on how to investigate every patient minimum, ideal, and complete. With the promise to keep a watch on time, I would like to present three scenarios. As a part of our institute's mobile diabetes clinic, which goes to the rural and tribal areas, I often get to see patients who are from rural and tribal areas. Their first question is, what is lipid? Why should I use this medicine? Why should I do this testing? And why should I take the medicine? They don't know anything about it. Our representation is, let's say, Mr. Rambha, who has the basic questions of why we are doing all this. In the routine clinic, I get to see patients like, let's say, for example, Mr. Sharma, who is a retired bank officer and trying to fit in the medical bills, the investigation bills into his post-retirement plan. And he asks me how often I do check my lipid profile, which is medicine and testing fit into my post-retirement plan. And probably occasionally I do get patients like Mr. Mittal who can afford a gold-plated Rolex watch. So we are going to see what is going to be an ideal lipid panel for each one of them, considering the resources not affecting the clinical effect. So that is what is going to be in today's presentation. To highlight why we are worried about the lipid evaluation and treatment in each setting, I would like to put you a question which might be hypothetical but is very alarming. So this is a prescription of Mr. Rambha, a tribal patient, and this is the prescription you are doing. I would like to again say it might be a hypothetical but alarming question. If I am asked to choose one medicine from this prescription to prevent a coronary artery disease genetic future for this patient, what would you like to choose? And the answer is this statin. I am sure you are all worried about the microvascular complications, agreed. You are worried about the other risk factors, agreed. But if it is for prevention of coronary artery disease, we have seen that nothing works as good as reduction in the lipid pattern, not even reducing your blood sugars. I'm sorry to say this in a diabetes conference, but the odds ratio for prevention of cardiovascular disorders in diabetic patients is higher for the lipid management than for the blood sugar management. So I'm saying that not that the other factors are not important, but probably the single most important modifiable risk factor for prevention of coronary artery disease is dyslipidemia. Now, to make an ideal lipid evaluation meaningful, we have to keep in mind that it is not only lipid evaluation, it is an evaluation for coronary risk for the particular patient. And there are three important aspects of this evaluation. One is clinical evaluation, where we have to keep an eyes open for considering the consideration of age and very importantly family history of premature coronary artery disease in a particular patient. In clinical examination, we must look for pre-senile arcus or xanthelasmas and xanthomas. So keep your eyes open for these things. Second is laboratory evaluation, which is the most important focus of today's presentation. When it comes to the parameters of lipid panel, then again looking into the theme of the presentation, minimal, ideal, and complete. I would like, before going to the actual laboratory evaluation, to spare a couple of minutes as to understand what are these lipids, a little biochemical basis of these lipid evaluation. Now it is all about a lipoprotein particle. This single lipoprotein particle, which is consisting of three major things from our evaluation point of view. One is a protein called as apolipoprotein, second is triglyceride, and third is cholesterol. So each molecule which we are looking at consists of these three important things. And I would like you to keep this in mind. Now, depending on the density, percentage, and the size of the particle, and density of proteins, cholesterol, and triglycerides, these lipoproteins are classified into these classes. And these are chylomicrons, VLL, IDEC, that is intermediate density lipoprotein, low density lipoprotein, and high density lipoprotein. To make it a clinically important issue, we have to remember that this density in low density lipoprotein doesn't relate to the density of cholesterol or triglyceride. It relates to the density of protein. It relates to the density of apoprotein in food. So, your LDL will have a low density of apoprotein. This is in red is the density of lipid and the blue is density of protein. So you can see from very low density to high density, the protein density increases and the lipid density goes down. So larger the particle, lower the density of our protein, the molecule is not good for your heart. And this is important to remember when we are reading a cholesterol or lipid panel report. As we said, going to the theme of the presentation, we are going to have lipid evaluation, which will be one into routine practice, another extended lipid panel, and advanced test, which will be ideal or more than ideal. In routine panel, we all do triglycerides, total cholesterol, LDL cholesterol, HDL cholesterol, VLDL cholesterol. We also can calculate non-HDL cholesterol as well as ratios of good cholesterol as to bad cholesterol. In extended lipid panel, we would like to do the levels of apolipoproteins in the blood, and in advanced test, we would have qualitative analysis of LDL particles as well as genetic tests. I'm going to go through all this individually. Now, coming to the routine lipid panel. Even in the routine lipid panel, it is important to understand what is the method by which the lipid panel is evaluated, and that there comes the setting or the source setting which is important. In most ideal clinical setting, the lipid panel is done in an auto-analyzer or a semi-auto-analyzer for that matter. And these analyzers most ideally will measure each and every subclass and each and every lipoprotein in a given panel. So that will measure total cholesterol, it will measure HDL, it will measure LDL. And cost of this analyzer will go somewhere up to 10 to 20 lakh rupees. And for the patient, for each panel, the cost will go up to 800 to 1000 depending on what the lab is charging. On the other side, where the resource settings are poor, this is our mobile diagnostics clinic, and this is a machine which is commercially made available by IDEC, which uses a boron affinity method for point of care testing of lipid profile. We are talking about minimal data, we are talking about ideal, and we are talking about possible. So it is not possible to take this analyzer in the periphery, but it is possible to take this analyzer to the community. And this will cost somewhere around 1 to 2 lakh rupees, and each panel will cost around only 300 rupees. Now, going away from the ideal and non-ideal situations, if I do not have a auto-analyzer or semi-auto-analyzer, or if I do not have a way to directly calculate my LDL, I can make some calculations. So, whatever machine which tests your lipid panel definitely will directly measure total cholesterol, triglycerides, and high density lipid. This is enzymatic methods by which we measure direct measurements of TC, TG, and HT. Now, what is in question is LDL. We are always talking about LDL because that is the molecule which is going to cause the atherogenic risk. Now, if I have to calculate LDL, a simple equation, we all know what does total cholesterol contain? High density lipoprotein, low density lipoprotein, and very low density lipoprotein. Now, if I need to measure VLDL, it is difficult, but pathophysiologically it is seen that 20%, that is 1/5 of your triglycerides is contained in VLDL. So the VLDL is replaced by triglyceride divided by 5. Now I have in my equation all the parameters which are directly measured. I have total cholesterol, I have VLDL or TG by 5, and I have HDL. Now I just have to calculate LDL. So in the same equation, if I do mathematical changes, HDL goes this side and becomes minus because it goes on the other side. TG by 5 goes this side and becomes minus. I'm sorry about the misalignment because of changing the PowerPoint. But the LDL becomes total cholesterol, which I am measuring directly, minus HDL cholesterol, which I am measuring directly, and minus VLDL or triglyceride by 5. So I can derive LDL from these three measurements. It's important to remember that when I am measuring this, my triglycerides have to be below 200. This calculation doesn't work when the triglycerides are more than 200 and doesn't work at all if the triglycerides are more So if you are trying to measure LDL from derived values, you need a fasting sample. This is probably the most important slide of the presentation, and not because this is my cholesterol report, but because it shows how to read cholesterol report. And the most important thing is to read what method is used to check the cholesterol. So when you are, even most of the auto-analyzers, semi-auto-analyzers will measure directly only total cholesterol, triglycerides and HDL and will derive LDL. And obviously for the logical reasons, directly measured LDL is much more reliable than measured LDL, especially when the triglycerides are higher. Now this is a million-dollar question, which everybody is now talking upon. Whether you need a fasting lipid panel or non-fasting lipid panel is fine. If the resources are poor, if I am not sure if my patient will come back or not, if I am in a resource poor setting, then we can go ahead with a non-fasting sample. If I am doing a direct measurement of LDL, I am not deriving my LDL from triglyceride, it doesn't matter whether I am doing a fasting lipid panel or a non-fasting lipid panel. If I am trying to measure lipoprotein, it has no effect on fasting or non-fasting. Fasting becomes important when you are trying to derive your LDL from triglycerides or you are dealing with a primary triglyceride problem, a hypertriglyceridemia or hypertriglyceridemia on treatment, or you are trying to calculate the residual risk on a patient who is treated on maximum doses of treatment. These are only few conditions where mandates you to make the patient come back in fasting. Otherwise, non-fasting lipid panel is absolutely okay. Coming back to the extended lipid panel, we have seen what routine we are doing and how we do that, what is the methodology. Coming to a little extended lipid panel, many laboratories do measure the levels of apolipoprotein B and A in blood. Now, what are apolipoproteins? As we saw, as part of the lipoprotein molecule, apolipoprotein are the protein counterparts of the lipoprotein molecule, and they decide what happens with the lipoprotein. To make it very simple, there are apolipoproteins which take the cholesterol or lipoprotein from the liver to the blood, and there are certain groups of lipoprotein which take it back from blood to liver. So whatever bad molecules, so-called bad cholesterol molecules, that is VLDL, LDL, they contain apolipoprotein B. So remember B for bad. And apolipoprotein A is majorly responsible for taking this cholesterol and triglyceride molecule back to the liver, which we call reverse transport. So remember, when we are testing apolipoprotein B, it is bad, it should not be high, and if I am checking apolipoprotein A, it is good, it should not be low. Coming to a little more advanced things, qualitative LDL particle size or number of the particle. We all know that the LDL mass which we are measuring is probably the most important clinically significant factor. But to understand what are LDL particle size, I would like to look at these popcorns. So these popcorns, apart from increasing the cholesterol, are also going to help us in understanding the LDL particle. So look at these popcorns. One popcorn tub is actually a lipoprotein particle, and the popcorn inside it is cholesterol. So look at this diagram and look at the other diagram. Both of these have similar amount of LDL cholesterol mass because both of them contain equal mass of popcorn. But one side there are 5 particles, other side there are only 3 particles. In the 5 particle side, the LDL particle size is higher and the particle size is smaller. So they are more dense. So this higher number of particles amounts the same level of mass of cholesterol are worse compared to the large LDL particles or low number of LDL particles. Because these are higher, these are more dense and they can go through the endothelial linings, the number of particles increase and the size of the particle reduced is worse amongst the same number of mass of LDL cholesterol. So even if both of them have the same mass, the particle size and the particle number does not. That requires nuclear magnetic resonance imaging, and commercially for patients who are not yet doing it, still in research, we are not using it to be in practice, but it is something which may come in future and we must know. Now, why we are all doing this lipid evaluation? Because we want to correlate it clinically. And when it comes to clinical correlation, I found this very useful and simplistic diagram, which is published in the Indian Consensus of Lipid Management. And this diagram tells us that the first thing you should look into a lipid panel of a patient is triglyceride. And that is not for cardiovascular risk. That is for acute pancreatitis risk. If your triglycerides are more than 500, that becomes the priority and we need to cut it down. But if your triglycerides are less than 500, you need to identify the most important risk factor for coronary artery disease, and that is the low density lipid. That is LDL. So we need at least minimal triglyceride and we need LDL. Now we all know the conventional atherogenic triad where there is high LDL, high triglyceride and low HDL. We all know the reasons behind why LDL is bad, because it is small, it can cross through the endothelium. It doesn't have the apolipoproteins which take it back to the liver, so it is exposed to the blood and oxygenation for a long time. So it gets oxygenated and the atherogenic levels rise. And probably one of the most important reasons why we know that LDL is important, because reducing LDL by pharmacotherapy has shown consistently in improving the cardiovascular outcome. I'm sure the trials are pipeline, but none other therapy has consistently shown that treatment with particular drug to particular abnormality has correlated into improvement in the clinical cardiovascular response. So we know LDL is good, and LDL is a good risk marker, and reducing LDL reduces the risk. But there is still something left, that is called residual risk. As Dr. Shah sir mentioned correctly, this residual risk is conferred by many factors, including your blood pressure level, blood pressure variability, and lot of other factors. But because we are talking about lipids, in lipid panel we are going to see how to evaluate for this residual risk. Because we have seen how to evaluate for LDL, now we are going to see how to evaluate for the residual risk which confers apart from LDL. Now into this conventional lipid atherogenic trial, there is an extension of this conventional atherogenic trial also, and this circle extends more than LDL to all the particles which are triglyceride rich lipoprotein particles. Amongst that, LDL is the major one, but apart from that, there are other triglyceride rich lipoproteins which are responsible for atherogenesis. Now we have to see how we evaluate for them. And here comes your extended and advanced lipid panel. So apart from your LDL cholesterol, there are LDL particle size, number, which we are not commercially using, which can also be indirectly measured by measuring your ApoB if you are able to do that. If you are not able to do ApoB, even your routine lipid panel can give you an idea about this extra LDL triglyceride rich lipoprotein panel, and that can be done by calculating your non-HDL. And non-HDL is simply total cholesterol minus your HDL. The targets, the treatment, we are going to discuss subsequently. But here, how do we evaluate for this extended circle is by evaluating non-HDL into simple routine evaluation for lipid panel. Now there is another way of checking it, and that is by checking the ratios of good cholesterol and bad cholesterol. Number of laboratories will give different numbers, like this total cholesterol by HDL, LDL by HDL. So basically it's a good cholesterol divided by bad cholesterol. Unfortunately, we do not have what are the normal limits for this, and we do not know how they correlate with clinical coronary artery disease. So very beautiful trial published just last month saying what apart from LDL confers this risk. And they have found that equally important are lipoproteins, PCSK9 and non-HDL. We are going to talk about it in short. So we saw that minimally we need triglycerides, we need HDL. To extend the clinical evaluation, we can have non-HDL and ApoB if it is possible for you. And then comes HDL, which is important as a negative risk factor. So if you have 3 risk factors in your clinical profile, and if you have HDL of more than 60, one risk factor gets minused. Evaluation of secondary dyslipidemia is important, especially ruling out hypothyroidism, nephrotic syndrome, and corticosteroid excess, which are probably the most common reasons for secondary dyslipidemia. To complete the coronary risk evaluation, we have to look into the atherosclerosis cardiovascular risk in given particular patient. Now there are a number of risk calculators. I don't want to say which one is better than the other. If you are dealing with an Indian patient, which we all are dealing, and he has diabetes, he will come into a high risk category. So without even calculating the risk, Indian patient with diabetes is high risk. Consider it as high risk. It is important to have a look at extremely abnormal lipid values on which a lipid clinical specialist will come in to picture, and these include triglycerides more than 1000, obviously for the risk of acute pancreatitis, LDL more than 500, less than 10, or HDL less than 10, which are basically genetic familial hypercholesterolemia or genetic avital hypercholesterolemia. You would not probably deal with these patients very commonly, but what you might deal commonly with is LDL more than 190, which has also been recognized by ADA and other AAC and other lipid guidelines. And these are the things where our Mr. Mittal is going to get shortly benefited. And because LDL more than 190 or LDL not responding to the maximum doses of statin, you are probably dealing with a genetic disorder and a heterogeneous genetic disorder. And for these, we are shortly going to have treatments in form of mitochondrial triglyceride transport protein inhibitors, or PCSK9 inhibitors, and anti-sense. Though we do not have them available in India right now, they might become shortly available. And we must know how we evaluate the patient so that we can refer the patient for some sort of therapy. And the evaluation will mostly include patients who have heterozygous familial hypercholesterolemia. Homozygous is very rare, possibly 1 in 250,000 patients, but heterozygous is not very rare. One in 250 to 500 patients can have a heterozygous familial hypercholesterolemia. So it's very likely that we will be one of them. And if the evaluation is needed for such a patient, currently what is recommended apart from clinical evaluation and a lipid profile report is a genetic testing for mutation for a particular heterozygous gene. And there are going to be evaluations which will come in, let's say, in this decade or 15, 20 years later, which will include evaluation for LDL receptors and level of this protease enzyme that is called PCSK9. So coming back to what's the time, here I have Mr. Ramkau. I will ask him to test point of care machine, at least directly measure triglycerides and calculate LDL. Non-fast example is okay because I am not going to get this patient. Mr. Sharma, direct LDL would be ideal. Non-HDL calculation is important, and possibly if the risk is very high, I would ask him to get an OB done. And probably a few years from now, I would have genetic testing available for Mr. Mittal and the treatment in form of PCSK9 and anti-sense. With that, I would like to end this evaluation panel, and I would like the moderator to take on the session to the next stage.
Thank you, Doctor.